We're talking about blood vessels, and so you know the circuit from the heart. Anything going away from the heart is an artery. The artery is going to become an arterial. The arterial is going to become a capillary. The capillary is going to become a venule. The venule becomes a vein, and it goes back to the heart. In general A&P, we talked about the different types of blood vessels, like we talked about the elastic arteries, which are the aorta and the pulmonary trunk. And then we talked about the muscular arteries, the ones that we name, like the axillary or subclavian. Those are ones that we name. We don't name the arterioles. We don't name the capillaries. They kind of hang out in beds. We don't name the venules. Then we have medium-sized veins. And then we have the superior and inferior vena cava, which are the large veins. Okay, so we've talked about that in general A&P. And that's just kind of saying, here's the difference between arteries and veins. Arteries are moving blood away from the heart. Veins are bringing blood toward the heart. The vessel walls are thicker in arteries. That's why if you are to section an artery, it's not going to collapse on you. But if you section a vein, it could collapse. Okay. And then veins also have valves, which arteries don't. Right? So there's just some differences between them. With the arteries, so this is that loop that I was talking about that I went so fast on, but the elastic arteries are the large arteries like your aorta and your pulmonary trunk. So there's only two of those. And they lead into muscular arteries, and these are all those medium-sized arteries, the ones that we name. They branch off into smaller arteries, which are arterioles, and then arterioles become capillaries. And capillaries are the only place where you get an exchange with the interstitial fluid. All the other arteries, they're just a transport system. That's it. And then the capillaries are going to merge together to become venules. Venules merge together to become medium-sized veins, and we name those. Axillary, brachial, all of those, subclavian, right? And then they have valves, so they help to prevent the backflow of blood. And then those medium-sized veins are all going to merge into the large veins. And there's two large veins. There's the superior vena cava, and there's the inferior vena cava. Also in general A&P, we talked about the different types of capillaries that there are. We have continuous capillaries. So capillaries, if you remember when we were talking about the different layers, I know you have to identify the layers of a blood vessel for lab. So there's the tunica intima, which is the very innermost layer, then the tunica media, which is muscle, smooth muscle, and then the tunica externa, which kind of holds that blood vessel in place. The tunica intima is the very innermost layer of that tunica intima is made out of endothelial cells, so like simple squamous endothelial cells. And so these continuous capillaries, they don't have the tunica media, they don't have the tunica externa. All they have is that endothelial lining. So it's very, very thin, and that's why we're able to get things across it, because it's just a very thin blood vessel. And so most of your tissues have these continuous capillaries. There's nothing really special about them other than they're just it's an endothelial lining. It's nice and thin, so things can get across it. Water, ions, small molecules like glucose, amino acids, gases, a bunch of things can get across it. Then we have these other ones that are called fenestrated capillaries. Fenestrated capillaries are just like continuous capillaries, except they contain pores. Fenestrated kind of means windows. So there's more things that can get out faster when we have fenestrated capillaries. So we think about the areas of the body where you have to get things out of the blood vessels really fast. So we think about the endocrine organs, like your hypothalamus. You know, the hypothalamus is making hormones. It has to get those hormones into the bloodstream fast, right? And the pituitary, same thing. The pituitary is making hormones. It's got to get the hormones out of the pituitary and into the blood fast as that blood is traveling by. Also in the intestinal tract. So in your intestines, you're absorbing nutrients as it's going through the digestive tract, through those intestines. You want those nutrients to be absorbed quickly. Kidney filtration's another place. In the kidney, in the glomerulus, we have filtration. Blood goes into that, into the glomerular capsule, into the glomerulus. Those capillaries are fenestrated so that you can filter the blood through that membrane, through that endothelial lining. Then we have sinusoids. Those are the third type of capillaries. They are actually fenestrated capillaries, but now they have gaps in between those simple squamous cells. So now we've got big gaps that can allow big things through, big things like cells. So we can allow cells into the blood from these other organs. So we look at the liver. The liver makes plasma proteins. So we can get the plasma proteins from the liver, those hepatocytes, into the blood through those gaps. We look at the bone marrow. The bone marrow makes blood cells. We've got to get those blood cells into the blood vessel. So they're going to go through those gaps in those capillaries. Okay? The spleen has to release red blood cells if there's a crisis, if there's a hemorrhage and we've got to release red blood cells from the spleen. Then the red blood cells will be able to quickly go into the blood vessels from the spleen. Okay, so those are all the different types of capillaries. Let's look at a capillary bed. Right? So we have blood that is flowing away from the heart down the arteriole. And then the blood is going to go into a capillary bed. Right? So those capillaries are so small that you're not going to have like a single capillary. They're all going to be in this, this grouping of capillaries that we call a capillary bed. Right? And so when the blood enters into the capillary, we'll give names to the sides of the capillary. So on this side, it's closest to the arteriole, because this is the arteriole right here. So we say that this is the arterial end of the capillary. And it's moving away from the heart, so it's still full of oxygen, so the blood's going to be red. Right? Then, because we can exchange things in this capillary, oxygen is going to move out, and the blood's going to become more blue because now it has less oxygen. We say it's deoxygenated. And so by the time we get to the venous end, the blood is going to be deoxygenated, and then it's going to head back to the heart through the venule and then the veins and then the superior and inferior vena cava. So it's always working in a loop like this. We always move from the arterial end over to the venous end, right? So that's always going to be the way that blood flows. It never comes to an end. It's always a circuit. It goes round and around. And this is going to be important for us to know, the arterial end and the venous end, because we're going to talk about capillary pressures, and you have to know where each one of those are. Okay? Down here at the bottom, this is showing what's called an arteriovenous anastomosis. And sometimes that occurs where you don't really have a capillary then. You have just an artery that becomes a vein and then goes back to the heart. So in this case, should get rid of that. in this case, you're not going to have any exchange, and you're going to end up with a little bit of oxygenated blood in those veins. Okay, so that's an arteriovenous anastomosis. But the capillary bed with the arterial end and the venous end is what I really want you to keep in mind. The veins have valves in them. And so the valves, this is showing, this is the vein here. And you can see the valve. It's a lot like the semilunar valves in the heart. So when blood is moving in this direction, those valves are going to be open. They just are, through pressure, they just open up. But when the heart stops beating and blood tends to move towards gravity, that causes those valves to close. And that way blood doesn't pool down near your ankles, right? So it keeps, those valves help to keep moving the blood towards the heart, not letting them fall down because of gravity. Okay. There's some other things about veins. Veins expand easily, like a balloon. And so they can actually store a lot of blood. They can be blood reservoirs. And so we end up calling those the capacitance vessels. Capacitance vessels. And we can get some venoconstriction. Most of the time in here we're going to be talking about the arterioles and arterial constriction. When the arterioles constrict, there's so many of them. There's such a huge cross-section of them that they can really affect your blood pressure. But on occasion, if you have hemorrhaging, your veins will constrict too. But most of the time when we're talking about vasoconstriction and vasodilation, we're talking about the arteries and the arterioles. We're not talking about the veins, venoconstriction. With the veins, there's this thing called the varicose veins, and varicose veins are distended veins. That's when there's a weakening in the vessel walls, in the walls of the veins, and they just distend. They kind of, balloon out. And so we have superficial veins, and some people think that they are unsightly, so they can be shut down through sclerotherapy, through injections. It'll just collapse the vein completely and then get rid of them so you can't even see them through the skin. But sometimes we have deep varicose veins, and those are more of a problem because those can be called the DVTs, a deep vein thrombosis, which is basically a clot it happens in in the the blood's moving really slow in those deep veins, and the clot just kind of sticks to the wall of the veins and causes a DVT. Okay, and a person can get their legs are usually where that occurs. Their legs will get really red, and you can tell that the blood's backing up, and they're getting slowing down of blood. It can impair venous return, but the concern about these things is that they can dislodge, and when they dislodge, they become an embolus. And emboli can travel up and lodge in maybe your lungs, and that causes a pulmonary embolism, and that's a big issue then. Okay. Okay, and then next, and still this is all review stuff from general A&P, which is okay, right? So we're going to continue with this. We're going to talk about capillary pressure and resistance, all right? So this is all about the capillaries. And we're going to talk about capillary blood flow. So that is just how fast is the blood flowing through that capillary. When we talk about blood flow, it's how fast is it flowing, right? Or how much is flowing, okay? Pressure is going to be anything that will increase that blood flow. What's making that blood flow forward? right? That's what pressure is. And then resistance is anything that decreases the blood flow. What's slowing that blood flow down? So there are some different pressures that affect blood flow. So we're going to look at those. The first thing is arterial blood pressure, right? So we're looking at arterial blood pressure means blood pressure in the arteries. So the first artery that we have coming away from the heart is the aorta. And at the aorta, the blood pressure is 120 millimeters of mercury. Okay, so we always measure pressure in millimeters of mercury. So the blood leaves the heart through the aorta, it goes down through the aorta, it starts branching and branching and branching, and finally it gets all the way down to the capillaries. Okay, so this would be the arterial end of the capillary. And at the arterial end of the capillary, the blood pressure is 35 millimeters of mercury. So it's already decreased from 120 all the way down to 35. Right? And then as it moves through that capillary, the capillary is really tiny and red blood cells are moving single file and it's slowing it down quite a bit. And the pressure then at the other end, which is the venous end of the capillary, is going to be 18 millimeters of mercury. Okay. And then by the time that blood gets back up to that inferior and superior vena cava, that blood flow has gone down to 0 millimeters of mercury. So it's pretty much at a dead stop. You know, there's not much pressure there. So the pressure is different than the velocity. We're going to see a chart that shows the differences between these things. So the blood flow is just how much pressure is pushing that blood through these vessels, right? Okay, so this capillary hydrostatic pressure, we'll see that again. The hydrostatic pressure is just the blood pressure in the capillary. That's what capillary hydrostatic pressure is. So we've got the capillary hydrostatic pressure at the arterial end, and so that's CHP at the arterial end, and then we have the CHP at the venous end. Okay. And then that venous pressure was the last one that I talked about, where we went from the 18 millimeters of mercury at the start of that venule, which is at the end of the capillary, and then that goes up to the superior and inferior vena cava, where it becomes 0. Okay, so we're just looking at pressures there. Let's look at the 3 things that affect resistance. So we'll start with the first one, which is vascular resistance. So again, if we look at a blood vessel, just so I can show you here, there's our blood vessel, right? Blood flow, that's moving forward, right? Blood flow is moving forward. The hydrostatic pressure, that capillary hydrostatic pressure, is pushing that blood forward. But now we're going to talk about resistance. Resistance is friction. So friction can happen from a couple of things, then we're going to talk about that. But what resistance does is it slows down that flow. That's what resistance is. It slows down that blood flow. Okay. So let's look at There's the vascular resistance. There's two things that can create vascular resistance. The first thing is the length of the blood vessel, right? So here you have this is a normal blood vessel right here, and so blood's just moving along, and the blood that's closer to the walls of the capillary, they're hitting friction. Like if you rolled a ball down the carpet, it's hitting the carpet and it's getting friction and it's going to slow down. So the longer the hallway you have, the more friction that ball is going to have on the carpet, right? So if we have a blood vessel that's twice as long as another blood vessel, that's going to it's going to decrease the blood flow by half. It would basically increase resistance twofold, which means your blood flow gets cut in half. So now you've slowed the blood flow down to half of what it should be. The pressure, not the velocity, but the pressure is about half of what it should be. Okay? The other thing that's under vascular resistance is vessel diameter. Vessel diameter. So vessel diameter actually has a much bigger impact on vascular resistance than length of the blood vessel does. You know, as far as blood vessel length goes, you know, your blood vessels are the same length throughout your whole adult life. You have the ability to grow new blood vessels in areas, but the length typically stays pretty much the same unless you gain weight, lose weight. But it's just saying that there's one blood vessel that's going to be longer than another blood vessel. Okay, so that's just showing the differences in vessel length in different blood vessels. So the vessel diameter has a much bigger impact, right? If you have a normal blood vessel, you're having your normal blood flow and you're getting your resistance on the side. But if you cut the diameter in half, okay, if you cut it in half, and that can be done through either like vasoconstriction, can cut it in half, or if you've got plaquing, that can cut it in half, right? If you cut it in half, it's going to increase the resistance 16-fold. So that's a much bigger increase in resistance. So atherosclerotic plaquing, you know, that's not a good thing. It's really going to impact the blood flow. It's going to increase this resistance 16 times what it should be if you are narrowing your blood vessel because of plaquing, right? So that's really going to affect afterload, right? It's going to really put a lot of pressure on the heart and make the heart want to contract harder. Okay, the next thing that impacts resistance is blood viscosity. Okay, so with blood viscosity, viscosity just means how thick is the blood. Blood is, you know, much thicker, like 4 to 5 times thicker than water. It has, you know, the cells in it, and it has ions in it and solutes in it. So it's thicker than water is. And when you have a thicker blood, a higher viscosity than, you know, water, it's just going to require higher pressures to move it, right? Because it's thicker. You have increased resistance just because it's thicker. If we have a disease like polycythemia, that's a blood cancer where red blood cells are being overproduced. So now you have more red blood cells. Do you think that's going to increase or decrease the viscosity? Yeah, it's going to increase the viscosity. So it's going to be thicker. So your resistance is going to be greater, and it's going to take the heart's going to have to really work harder to push that blood through those blood vessels. Okay? But if we have something like anemia, and one symptom of anemia would be decreased red blood cells. It's either decreased hemoglobin or decreased red blood cells. Then that's going to decrease viscosity. You don't have as many cells in there, so it's not as thick. That solution's not as thick, and so that's going to decrease resistance. Okay? So there's things that can affect blood viscosity. And then the last thing that really impacts resistance in a blood vessel is turbulence. Now, turbulence is caused by a sudden change in a vessel diameter, and it ends up causing these eddies and swirls. It makes them swirl, right? And so we see this normally when we're going from the ventricle, which is a big chamber, up into the aorta, which is quite a bit smaller. That's a very sudden change, ventricle to aorta, to the aorta. So you should be getting these eddies and swirls in the aorta. So that's a normal type of turbulence. But if we have this atherosclerotic plaquing, like you see down here, where I drew in the plaquing down here, okay. Now the blood is moving along and it hits that plaquing, woo, and it starts to get these eddies and swirls, right? And that's turbulence. So the blood, there's turbulence there. And that's not normal. That's abnormal when we see that in other blood vessels. When you listen to these this turbulence, you're going to hear with a stethoscope what they call bruit. It's a very distinct sound. And so you can hear that maybe if they're listening to the carotid arteries, they're listening to the femoral arteries, right? You'll be able to hear these. These would be abnormal. Okay. Here's an overview of some of the cardiovascular pressures. So we're going to go through these one at a time. In this chart here, we're talking about the blood vessel diameter. And we're looking at how does the blood vessel diameter change from the aorta all the way to the capillaries and then back to the vena cava. Well, the diameter at the aorta is pretty large. It's about 2.5 centimeters. And then by the time you get down to the capillaries, it's very small. And then by the time you get to the vena cava, those vena cava are pretty big again. They have a pretty big diameter, right? If we look at the cross-sectional area, so the cross-sectional area is going to be, again, here we have the aorta. Now I just used A for aorta, C for capillary, and VC for vena cava. Okay. So the cross-section of the aorta, well, there's only one, so your cross-sectional area is very small. But then by the time we get to the capillaries, there are thousands and thousands of capillaries, so now your cross-sectional area is very big, right? And then the blood flows all the way down to the vena cava, and well, there's only 2 vena cava, so that at that time now your cross-sectional area is slow. It's how many square centimeters of blood vessel do we have? Well, not very many because there's only 2, right? Okay. Then here we can look at blood pressure. So again, we're going to compare the blood pressure at the aorta versus the capillary versus the vena cava, right? So we start out, and we've already talked about this. We start out at 120. We get to the beginning of the capillary, and now it's what? 35. We get to the end of the capillary, and it's 18. We get to the vena cava, and it's, yeah, it's going to be like 0 to 2, pretty much 0 by the time it gets back, right? So that's the pressure. Okay. Then we look at the velocity or the speed. And so if we, of course, at the aorta, so aorta, capillary, vena cava, at the aorta, it's going to be pretty fast. Those ventricles just contracted, the blood's shooting out, it's going to be pretty fast. You know, close to 35 centimeters per second, pretty fast. And then by the time it gets down to the capillaries, it just slows down. It's the slowest it's going to be. And that's good because that's where we do our exchange. We let nutrients out of the blood, we bring waste products into the blood, we let oxygen out of the blood, we bring carbon dioxide into the blood, so it's good. We need that to go slow. But now look what happens. By the time we get to our venules and now our veins, we start to pick up speed, right? So we're picking up speed as we're moving back to the vena cava. And so we talked about the two main reasons why this happens in general A&P. We talked about how skeletal muscle contraction, the skeletal muscles are squeezing on those veins and they're pushing that blood back up towards the heart, right? Back up towards that ventral cavity, the thoracic cavity. And the second thing is the respiratory pump. So every time you breathe in, you decrease pressure in your chest, and that kind of sucks the blood back up towards your thoracic cavity. Okay? So that respiratory pump is pulling the blood back up towards your heart. And then, of course, we have the valves that will prevent the blood from pooling down. It's not going to let it go too far down. Whenever the heart relaxes, those valves are going to close as the blood pressure, the blood starts to go back down towards gravity. Okay. All right, so we're going to talk about something that's called mean arterial pressure. So first let's talk about arterial pressure by itself, not mean arterial pressure, but just arterial pressure. So the pressure in the arteries, the arterial pressure has to be high enough to overcome that resistance because we always need blood moving forward. We don't want it to stop. We need it to move forward. So the pressure has to be high enough to overcome that. The arterial pressure is going to rise during ventricular systole, right? Does that make sense? The ventricles contract, so yeah, the arterial pressure is going to increase because blood is being pushed out of the heart. And then it's going to fall during ventricular diastole. So then as soon as the ventricles relax, now the blood pressure, there's nothing pushing it forward, the pressure is going to drop then, right? So at the peak of the ventricles contracting, we get a pressure there. We can measure the pressure at the very peak of that ventricle contracting, and that's called the systolic pressure. And then when the ventricle relaxes, at the very minimum, as soon as it's as relaxed as it's ever going to be, that's going to be our lowest blood pressure. That is called the diastolic pressure, right? So we end up recording our blood pressure then as systolic pressure and then over diastolic pressure. Systolic over diastolic. So, and normal, we've been saying, is around 120 over 70, right? So that's your systolic pressure at the peak of ventricular contraction, and 70 is your diastolic pressure at the when your ventricles are as relaxed as they're going to be. Okay? So then we have a couple more measurements here. the pulse is a rhythmic fluctuation in pressure that accompanies each heartbeat. So if we were to, I'm going to show you on a chart on the next page, but it's like one heartbeat, and you're looking at the pressure of that one heartbeat. Okay. The pulse pressure is the difference between the systolic and the diastolic pressures. So this is something that you would have to calculate. It's systolic minus diastolic, that's what the pulse pressure is. So if systolic was 120 and diastolic was 70, pulse pressure would be 50, right, okay? All right, but if we wanted to report just a single blood pressure value, like one beat, and we wanted to record that blood pressure at that one beat, we would use what's called the mean arterial pressure. Mean arterial pressure. And the equation for this is the diastolic pressure plus the pulse pressure divided by 3. So you have to know what the pulse pressure is. It's the systolic minus the diastolic. Okay? So let's look here at this picture up here.
So do we have to be able to figure that out?
You do have to figure that out. So you have to know the equation for a pulse pressure because you're going to be given just the heart rate, or you're going to be given the blood pressure, and you're going to have to figure out the pulse rate, and then you can put that into the equation to figure out the mean arterial pressure. Not on this next test. This is going to be on the chapters 21 and 22 test.
Oh, okay.
Okay? Everything I'm talking about today is not on your test. It's on your next week's test. It's going to be on the one after that, right? All right, so here's a graph. And so here we have each individual beat, right? So you have your heartbeat. So we have systolic, where it's really high, and then we have diastolic, where it's really low, and then we have systolic, where it's really high, and then diastolic, where it's low. Systolic, and then diastolic, right? So each one of these curves here, each one of these peaks, that's the pulse. That's the pulse. So to figure out what the pulse is, you take the systolic pressure and you minus the diastolic pressure, right? To get the pulse rate, or the pulse pressure, sorry, the pulse pressure. You take the systolic pressure minus the diastolic pressure, and that gives you the pulse pressure. Basically, what's the average, or what's the difference, not the average, what's the difference between the two, okay? The mean arterial pressure then, if we looked at this, this chart here, and we're looking up here, we can see the mean arterial pressure is the mean. It's sort of like in between, taking all the systolic readings and all the diastolic readings, and let's find just the middle of those. So we're finding the middle of all of those in between systolic and diastolic. That's what the mean arterial pressure is. And to figure that out, again, the mean arterial pressure is equal to the diastolic pressure plus the systolic pressure minus the diastolic pressure divided by 3, right? So if we had a person with a blood pressure of 120/90, the diastolic pressure is 90. The systolic pressure is 120. There's the diastolic pressure. So 120 minus 90 is 30. 30 divided by 3 is 10. So our mean arterial pressure would be 100. See, so that's how you figure that out. So yes, you will have to do that on our chapter 21, 22 test. All right, then next we're going to talk about the exchange that occurs at the capillary. And so when we come back next week, we're going to really talk about this a lot. There's a lot of details that we're going to go over next time. But capillary exchange is just, remember, the capillaries are the only place where you can exchange things with the interstitial fluid. So oxygen can leave the capillaries, carbon dioxide can come into the capillaries, water can leave or come in. There's 3 different processes that are involved with capillary exchange. We have diffusion, filtration, and reabsorption. So I'm going to just explain to you what each one of those things is. We'll start with diffusion, right? So diffusion, we already know what diffusion is. It's the movement from high to low. The movement of solutes from high to low, or the movement of water from high water concentration to low water concentration, right? That's what diffusion is, going from high to low. So when we look in the capillary and we see the diffusion of some of these things, water, ions, glucose and amino acids, which are nutrients, urea, which is a waste product, gases, fatty acids, steroids, those things can all diffuse across the membrane of the capillary. They do it in different ways, but I'm not that concerned that you have to know the exact way that they do it. All right? Are they going right through the endothelial cell? Are they going in between the endothelial cells? I'm not concerned that you know that. You just need to know that diffusion is the movement of these things from high to low. And they can go in either direction. It's always going to move from high to low. But there's some things that are too big and will not be able to diffuse out of the blood. So things like the plasma proteins, those are big proteins. They can't diffuse out. They can't get through or in between those squamous cells that are lining that capillary. And then large water-soluble substances, those also are not going to be able to diffuse out. Okay? They're going to stay in the blood. All right, the second process is called filtration. Filtration is basically hydrostatic pressure. It's hydrostatic pressure. It's your blood pressure. So your blood is moving along at a certain pressure and gets into those capillaries. 35 at one end, 18 at the other normally, right? But that pressure is driving that blood against the wall of the capillary. So it's pushing things out. So it's pushing things out like water, small solutes. Those are things that can be filtered out of that capillary, right? So we've got filtration, and filtration is going to be different it's going to be different at the arterial end over here than it is going to be at the venous end over here. Why? Because our pressure drops from 35 to 18. So there's less pressure. You're going to get less filtration over here on the venous end. Higher on the arterial end, it's going to be lower on the venous end. Okay. Then finally, the last process that we're going to look at is called reabsorption. And reabsorption is basically done through osmosis. Okay, we did say that water could be pushed through, and we said that water could diffuse through, but this osmosis here, when we look at reabsorption, we'll see that water is going to move towards the solutes. That's what osmosis is, when water moves towards the solutes, right? So here we have water moving into the blood because it's moving towards those suspended proteins. It's moving towards the suspended proteins. So those suspended proteins in there are creating what we call the blood colloidal osmotic pressure, otherwise known as BCOP. They're creating that pull. They create the osmotic pressure and they're pulling water back into the capillary. Doctors will call it the oncotic pressure. So the oncotic pressure is just the osmotic pressure, how much blood, not blood, but how much water is being pulled back into that blood vessel. Okay. All right, so now let's look at our last pick here. And we're going to look at factors acting across the capillary walls, forces acting across the capillary walls. And we've talked about these forces. We just talked about them. Now we're going to put them into practice here. And so we have the arterial end here. This is an arteriole. So this would be the arterial end of the capillary. And this on this side is the venule. So this is the venous end of the capillary, right? And when we were talking about pressure, arterial pressure, that's the hydrostatic pressure. And we said that that hydrostatic pressure is 35 at the beginning of the capillary, and then it's going to be 18 at the end of the capillary. So the CHP stands for capillary hydrostatic pressure. And that capillary hydrostatic pressure is pushing fluid out. It's pushing water out, and ions are going to go with it, and small molecules are going to go with it, but it's pushing fluid out with a force of 35 millimeters of mercury on the arterial end and 18 millimeters of mercury on the venous end. Then we have that blood colloidal osmotic pressure. And remember the colloidal osmotic pressure, colloids just means large suspended things like proteins. So this BCOP is because of these big proteins that are in the capillary that are just normally in the blood. And so they really don't change from the arterial end to the venous end. They're going to stay pretty much the same. Proteins are there. They don't change much under normal conditions, right? So the pressure that these proteins have on the fluid, they're going to be pulling in the fluid with a pressure of 25 millimeters of mercury. 25 millimeters of mercury on both ends. So now we can look at net filtration pressure. Now that we have these numbers, that's what we're going to do. We're going to look at net filtration pressure. There's a couple of other pressures in here that I have not talked about. So if you look in the book, you're going to see these other pressures, but those other pressures basically have a value of 0. It's pressures of what's going on in the interstitial fluid, because that has hydrostatic pressure and that also has colloid pressure. Since they're usually normally 0, we're not going to mention them here, right? So instead, we're just going to deal with the two pressures that we have, capillary hydrostatic pressure and blood colloid osmotic pressure. So our net filtration pressure is going to be the hydrostatic pressure, so the capillary hydrostatic pressure minus the net blood colloid osmotic pressure. That's what our net filtration pressure is going to be. And then we can tell, is fluid moving out of the capillary or is fluid moving into the capillary? Right? Is it moving out or is it moving in? So let's look at the arterial end. At the arterial end, we have the net hydrostatic pressure is 35 millimeters of mercury. That's the capillary hydrostatic pressure. That's how much pressure is pushing fluid out. And that subtract the net colloid osmotic pressure, and that colloid osmotic pressure is pulling fluid in at 25 millimeters of mercury. Right? So in this case, the net filtration pressure would be 35, which is our hydrostatic pressure, minus the 25, which is our colloidal pressure, and that gives us the net filtration pressure of 10. So our net filtration pressure would be 10 there, right? Now, the more important thing here, though, is we look and we see that the hydrostatic pressure is greater than the osmotic pressure. So that means we have a net movement in which direction? It's the direction that's most important, right? Yeah, we have a net movement. There's more fluid moving out than there is fluid moving in. So we have a net movement of fluid going out at a pressure of 10 millimeters of mercury. Does that make sense? Okay. Now when we get to the middle, here of the capillary, our hydrostatic pressure is already slowing down. So now our hydrostatic pressure is 25, and our colloid osmotic pressure never changes, so it's still 25. So what's our net filtration pressure going to be right there? 0. So we basically, at the middle of the capillary, have no movement of fluid in or out. Right? And now we get all the way to the end of the capillary. Now we're at the venous end. Our pressure has really dropped. Now our hydrostatic pressure is 18. The colloid osmotic pressure is still 25. So now which direction is the fluid moving? Yeah, more is moving in. At what pressure? Yeah, it's going to be moving in. We'll say that it's -7 because it's moving in, but at 7 millimeters of mercury. It's pulling in at 7 millimeters of mercury. Okay. All right, well, ultimately, our net filtration was 10 over here, and then we had it being pulled in over there. So net we have, like, between both sides, you still have more fluid moving out than you have fluid moving in, right? Okay, so what happens to that excess fluid that's moving out? Well, the majority of it is moving back in, but there is an amount, like, 15%. That's an awful picture. 15% of the fluid that's moving out of the capillary is going to move into your lymphatic vessel. It's going to move into your lymphatics. 85% ends up going back into the capillary, and 15% ends up going into the lymphatics. And then what happens to the blood? What happens to that fluid once it's in the lymphatics? It's going to go into the thoracic duct, into the right lymphatic duct, and it's going to go back into the subclavian veins and enter back into your blood again after it's been cleaned out by all those lymph nodes. So it will eventually go back to the blood, that 15%, but first it's going to travel through all of those lymph nodes and get cleaned out and checked out. Okay? Okay, That's it.